Good afternoon, everybody. My name is Dr. Piroska Östlin, and I'm the Director of the Division of Policy and Governance for Health and Well-being here in the WHO European Office. I would like to welcome you all to this webinar. I think we have a very important topic to discuss, migrant health and preventing non-communicable diseases. And I would just like to say that migrant health indeed is a very important issue for many countries in the European regions and beyond, but also for communities. And it was quite obvious, it became quite obvious for us yesterday when we organized the WHO European Healthy Cities Network Summit for Mayors. And there were some 200 participants registered for this meeting. And indeed, the issue of migrant health and also providing access to migrants in their communities, in their cities, it popped up all the time. So I think it's a very important issue at the local level as well. And we need to acknowledge that much progress has been made in Europe. We are improving the health of migrants and refugees, and we also improving access to healthcare and social services. But there are still some trends that are very worrying, because these trends fuel the exclusion of the most vulnerable migrants and refugees from healthcare. And I think we still have much to do to improve the situation. And I would also like to say that this work is very much seeing Health 2020 in action. Health 2020 is a European policy framework for health and well-being. And it is very much linked to its agenda to improve health equity. And it is also very much linked to the agenda of the 2030 Sustainable Development ambition to leave no one behind. But so we have still much to do. We need to work across sectors. We need to involve many actors, and now we are representing many actors actually here. It's academia represented here, health service providers, international organizations, WHO, and also the European Commission. And we are here to discuss the issues, to find and fill the knowledge gaps, which is so important, not least for WHO in our efforts to try to support countries so they more efficiently, more effectively can address the issues around migrant health. And I would like to give the floor to you.
Thank you. Thanks all for joining us today, and thank you to the ones who are joining us online. I will be your moderator today. My name is Christy Feig. A little bit of background about me. I've spent more than 25 years really working to communicate public health issues and public health information to lay audiences. I started as a journalist with CNN, covering health and medical news there for 15 years, and then I went to the other side because I love public health so much, and was Director of International Communications for the American Red Cross, and then Director of Communications for WHO in Geneva with the last Director General. So you can see I have a bit of an obsession about communicating health information, and that it's understandable to lay people. And it's something that we deal with in many different health issues. Yet I probably cannot think of one that is more clearly a great example of this than the one that we're talking about today. With non-communicable diseases like diabetes, cancers, heart disease, stroke, chronic lung diseases, in populations that are not normally in that particular place. So you have different cultures mixed with different languages, and I'm really glad that I'm the moderator of this and not the one that's bringing the solutions. That falls to you three gentlemen. But thank you for joining us for this, because I think it is an extremely timely conversation for this. Now, us talking to you is no fun at all, is it? So we are going to get you engaged in the conversation. with Slido, our platform. If you're in the room, you can raise your hand and ask all the questions that you want. If you are online, I'm going to invite you to join us two different ways. If you are on a computer, you want to go to slido.com. If you are on your mobile phone, go ahead and download the app Slido. While you're doing that, I'm going to go back to the computer people. For the computer, you will see where the web stream is happening with this code, event code, and it's KHHM. It's hashtag KHHM for Knowledge Hub on the health of migrants. On the computer, you will see it below the web stream of this event. Once you enter the event code on your mobile phone, it will be very clear what's right there. In both cases, you can ask questions. You will see a box that comes up. You type in your question, and you hit send. It will pop up on the screen once Joseph works his magic, and he will be running those as they come in, taking a look at them. You can move them higher, all right? We'll have just a few of them up there, but if you see a question on your platform that you really think is something that needs to be addressed, you'd love to know the answer to it, it's better than the question you have in your mind, then you can hit a thumbs up and it will move it up the ranks, okay? So that's how you can push questions up and down, just with the thumbs up sign. If we get a lot of questions coming in, then I will turn to Joseph and see if there is a theme among them, because it's quite important to us that we get to as many different questions as possible. And if we do see consistent themes building, Joseph will pull those together into one question that we can take. Also, when we get to the Q&As, I will take several questions at one time, aiming for 3, some in the room, some online, so that we can get to as many different people as possible. Now, also on that platform, you can tweet. The record for online participation in this is just over 800. We would like to break that record today. So if you can tweet out to your friends and ensure that they have FOMO, the fear of missing out, invite them to come join us, and then we can get our online community going higher. So 2 different ways you can participate without asking questions. One is driving questions higher. The second is tweeting during the session. All right, now, what are we going to talk about today? That's administrative stuff done. We are going to spend the next hour and a half talking about non-communicable diseases, chronic diseases as they are often called, diseases that do not spread from person to person, in case we have people online that are new to this topic. We have some of the top experts, I would reckon, on this topic with us today. We have Dr. Charles Agerman, an associate professor from the University of Amsterdam. We have Dr. Morten Saldeman, professor from the University of Southern Denmark and head of the Migrant Health Clinic at the Odense University here in Denmark. And we have Gauden Galea, director of the Division of NCDs and Promoting Health Through the Life course here at WHO's Regional Office for Europe. Now, this is indeed a heavy topic that we're talking about. These conditions do not spread from person to person, but they lead to many deaths. I think the last count I saw from WHO was about 40 million deaths a year, and also that represents about 70% of global deaths annually. Left untreated, it can be equally bad, debilitating for patients, devastating for their communities, and also quite a load for the health systems of host countries of these migrants and refugees. And we're going to explore some of that as we go forward today. The questions that we hope to address, that we've come up with, we will also address yours. What is the latest research saying about the prevalence and the risk of NCDs? What factors exacerbate or lead to the development of NCDs amongst refugees and migrants in a host country? How can we prevent refugee and migrant populations from developing such conditions? And how can we respond with more effective public health interventions and improved health services? We have a lot of ground to cover, so we're going to go ahead and get started with our speakers. I'm going to ask each one of them to say a few words. I may ask a few questions to dig a little bit deeper so that you know the latitude of your question, of space for your questions. And then we will finish all three here. I may ask a few more questions depending on how well they have stuck to their time. And then we will open the floor to questions for the last 30 minutes or so. So with that, let me go ahead and start with Dr. Charles Ageman. As mentioned earlier, he is the Associate Professor in Public Health at the Academic Medical Center at the University of Amsterdam. He is the Vice President at the Migrant Health Section for the European Public Health Association and a Fellow with the European Research Council. His research focuses on epidemiology and the prevention of cardiovascular diseases and risk factors among ethnic minority and migrant populations in high-income countries, and also in populations in low- and middle-income countries. Finally, he is the project leader of the research on obesity and diabetes among African migrants, also known as the RODAM study. Charles, let me go ahead and toss it to you.
Thank you very much. I think it's a pleasure to be here and also give us the opportunity to talk about this topic. I think it's certainly timely, and it's really, really nice that the European WHO Europe is taking this on. So that is fantastic. Why are we actually talking about NCDs? I think we are talking about it because I think that it is one of the biggest problems facing the migrant and the refugee population today in Europe and also worldwide, actually. Over the years, there has been a lot of work going on, and most of the work traditionally has been on communicable diseases, of course, infectious diseases, which I think is important. But equally, non-communicable diseases is also very, very important because once particularly the migrant population start to settle in the country, this is a problem that they're going to face. And it's very important that this needs to be taken into account. In terms of research, what has been looking at NCDs purely has been on cardiovascular diseases in particular. And by cardiovascular disease, I mean, stroke, coronary heart disease, ischemic heart disease, and then the risk factor, which is hypertension, diabetes, dyslipidemia, and then chronic kidney disease. There has been also some work on cancers for the last few years, which also gives a very interesting perspective. But the studies, I can actually divide it into three key themes of how the study has been conducted. The first one has been basically looking at inequalities. By inequalities, I mean comparing the migrant and refugee population with the host populations. That has been the dominant part of the study so far. Another angle, which I think is equally very important, is what we usually refer to it as the role of context. For instance, if you compare similar population living in different countries, for instance, you might have the African population or South Asian migrants, or how does it actually, what happens if the same population live in Netherlands compared to living in Denmark? That's really provide a very interesting perspective. And the last one is the role of migration. By this we mean comparing the migrant population to those of the population where they left behind. In other words, comparing to the home countries. And this really helps us to identify the key factors, actually, that changes upon migration. So, based on the data that you have now, what do we know? In general, I mean, we can say that the migrant population in general have a higher burden of non-communicable diseases compared to the host populations, although with some exception. I might have to emphasize that. If you take a stroke, for instance, we know that for the migrant and the refugee population, it rates from 1.5 to nearly 3 times higher compared to the host population. The same thing also goes when you talk in terms of heart diseases. For instance, if you talk about acute myocardial infarction, you see that it's very high among the minority population. Even the North African population, the Moroccan population, who traditionally have been shown to have a lower rate when they compare to the host population, you're beginning to see that the advantage that they have are now evaporating. This population, traditional people seem to think that because of the Mediterranean diet, they have had an advantage. But once they move into different, their diet and things start changing, and then they end up being worse off. Another issue, it has to do with diabetes. Diabetes is one of the conditions that affect almost every migrant population or refugee population, regardless of where you are coming from. We've just done a meta-analysis recently, and what we found was that in all the population in Europe, migrant population from all walks of life, you see that the rate is nearly 1.3 up to 4% times higher compared to the European population, with the South Asian population being the most affected. And actually within the South Asian population, if you zoom in, you see that people from Bangladesh, for instance, is nearly 6 times more likely to develop diabetes compared to the European host population. The same thing also applies to hypertension. Hypertension, when you talk about hypertension, what is also very clear is that the African descent population appears to be the most affected, actually. Traditionally, we used to think that African Americans have been the people who suffer most from hypertension. But the African population in Europe now, the rate of hypertension is far, far higher than what is being witnessed among the African population in the US. Another issue is also obesity. Obesity is also a major issue, particularly among the women in particular. And this are cut across all population. When you talk the cancers, the data in terms of cancer shows that in general, the migrant population actually doing better compared to the host population. But I think you need to be careful the way you interpret the data. Because if you look at different types of cancers, then you see a very interesting patterns, particularly the cancers that are driven by infection, such as stomach cancer or hepatic cancer. Then you see that the migrant population are doing worse. And the idea here, or the discussion here, is that many of these populations have been exposed to the poor social circumstances before they migrated. So when they migrate, then some of these infection can occur and then lead to some of the higher rate of cancers that we are seeing among this population. Particularly, that Helicobacter pylori is one of the important causes for stomach cancer, and this tends to be higher among migrants, and that can potentially lead to the high rate that you see. Another issue has to do with social determinants of health, which basically I've just mentioned, the situation that people found themselves in. Many of these people already come from a poorer countries. They have exposed to poor circumstances, and you all know about the biker hypothesis that actually you are at risk in terms of some of non-communicable diseases such as cardiovascular diseases actually starts in the womb. So when people then get exposed to poor circumstances and then they move to richer countries, and in most cases they find themselves in the fringes of society, poor socioeconomic status in the host countries, difficulty in getting proper jobs and getting enough resources to buy healthy food. All this can actually contribute to the high rate of the NCDs that we see among this population. There is also an issue of the healthy migrant effect. Those people that are working in the field, this is a very well-known theory. And the issue is that because some of the migrant population tend to be young, when they come into the country, initially they tend to have a lower rate of mortality compared to others. So this is was the key concept of a healthy migrant effect. But over the years, this concept has been extended to almost every conditions. And in the process of doing so, we end up misinterpreting this concept. So, for instance, we know that diabetes actually is higher even before the migrants arrive in the country. So in this regard, the issue of healthy migrant effect doesn't apply anymore. So I think it's very important that we need to watch the way we apply this healthy migrant effect part. In terms of, intervention, certainly there's loads and loads of intervention that have shown to be very effective in addressing non-communicable diseases. But the issue with the migrant population is that many of them come from different cultures. So you cannot cut and paste some of the interventions that you know to work among the European population and just dump it on this migrant population. Actually, we need to try to adapt this, taking into account these cultural differences, and also, more importantly, to evaluate these interventions and see whether it works or not, and if not, why not, so that we can move forward from there. And I think that, the last point that I will mention is that, the moderator talked about the current project called the Reduct study. And the Reduct study, I think, has been quite unique, and it's funded by the European Commission. And the idea of the main project is basically looking at the role of context and the role of migration. And so that study basically compares African migrants living in the Netherlands, in Germany, in England, and also African population living in rural and urban Africa. And that has given us tremendous amount of insight as to why you see the high rate of NCDs among migrants. For instance, if you take obesity as an example, if you are a man and living in the rural Ghana, your rate of diabetes among Ghanaians in the rural Ghana is about 1%. If they move, or if they live in the urban part, it's nearly about, say, 6%. If they end up in London, you are talking about nearly 26%, the same population. If you look for women, it's actually about 8% in rural, nearly 34% in urban, and then over nearly 54% in London. So clearly, environment seems to be shaping the health outcome tremendously among these populations. If you also look at, I think also one of the interesting things about, in terms of when people actually do have these conditions, for instance, hypertension, it's very important that if people do have these conditions, they are treated so that the hypertension can be controlled. We found in our data, in the Reduct data, that people with hypertension, in other words, who are hypertensive and have blood pressure of nearly 110 and over 180 systolic and 110 diastolic, in Europe, and particularly in America, we call this hypertension emergencies. In our data, we see that nearly about half of this population in Europe actually are walking around without being treated. There's a lot of treatment issues here. Why is it that these people are not getting the medication that they need? Is it because they cannot work through the system properly? So there's a lot of issue in terms of how we can actually encourage these people to receive better help that they need. So lastly, you've also luckily just received a very important grant from European Research Council called under the consolidation grant. So the idea is to help us to follow these people over time, to help us to actually to identify the key drivers which is driving this. So probably in the next couple of years, we should be able to get more information to help us to develop appropriate also risk models to be able to prevent the high rates of this condition that you see as migrant. Thank you very much.
Thank you very much, Charles. I appreciate it. And I wanted to follow up for just a second on that last comment that you made. We know well some of the drivers, as you were talking about there. Well, what do we need to do to understand more about prevention in these communities?
I think it is very important that we have more longitudinal studies, or what you call the prospective studies. I think one of the issues is that within Europe, for instance, if you look at the treatments, algorithms that are currently being used, it's all based on the European populations. And the reason is that we do not have a cohort that can actually help us to really identify the key factors. For instance, if you look at cardiovascular disease such as SCORE, which is being used, kind of, if you like, a model that you can actually calculate to see the cardiovascular risk. You know that some of these risk scores actually is not appropriate for the migrant population, but it's being used because there is no alternative. So that means that we need more prospective cohort, like I'm just describing the Prox-Rodam study. Luckily, there are some studies which currently going on our own team, such as the Helios study in Amsterdam, which we've already recruited about 21,000 migrants and the Dutch population to follow them over time. But we need to have this in different countries so that we can follow these people over time and to help us to really identify the key factors which is driving this. So certainly, longitudinal study and prospective cohort is absolutely crucial.
Thank you. One last question, if I may. You were talking a little bit about some of the well-proven interventions that we know with NCDs. How do you have to modify or adapt them, I suppose, for these different communities?
I think that in terms of adaptation, because the migrant population tend to have a different cultures, I think it's very important that we take these cultures into account. Many of these population, for instance, come from collective societies. So that when they end up in the individualistic societies, it becomes very hard. So some of the interventions actually are targeted on individual basis. So it might not work. So we need to take this into account. And I think what has been very successful, for instance, in terms of the African population in the US, has been the religious approach, in other words, the faith-based approach, whereby you give your intervention, but you based on religion, because usually people tend to trust, this group, and these also pastors and the mosque, and these people that are very powerful, and whatever they say are taken more seriously rather than me going there and telling people what to do. But we need to sort of adapt this, taking this into account and see whether it works or not, and if not, what is not, so that you can identify the gaps to help us to implement this. So I think it's very, very important that all these interventions that we are known to work very well, we start testing them. But to test it also means that there should be a support from each member states to support this part so that you can make a difference. Because I think the point is that it also have economic benefit, not only for the migrants, but also for the host population. Because if you make a prevention studies, it's actually prevent cost. If you're not, and the minority population, migrant population get a stroke, the cost is very, very high. So it's the interest of both the migrants as well as the member states to take these issues very seriously, because in the end, it is a win-win for everybody if you tackle migrant health.
Terrific. That summed it up very nicely, the importance of trust and different sources for trust with different people, I suppose. Yeah. We'll have more questions for you down the road. Morten, let me come to you now. Dr. Morten Soderman is a professor in migrant and global health at the Center for Global Health in the University of Southern Denmark. He is also a medical doctor and head of the Migrant Health Clinic at the Department of Infectious Diseases in Odense University Hospital. His research includes migrant health, patientology, living with chronic illnesses, vulnerability, nutrition, and mental health in post-conflict settings. Very clear why you're here today. Morten, let me go ahead and turn the floor over to you. Thank you.
Thank you. As you say, I specialized in infectious diseases and worked in West Africa for many years with health research. And when I came back, every time we had a patient with brown eyes or an accent, they said, "You've been to Africa, you know about these people." So I ended up having these outpatient clinics filled with people with accents and brown eyes. So in the end, I suggested that we sort of try and systematize the information that these patients have. So I asked the hospital management to start a small outpatient clinic in a public hospital and try and have a closer look at these patients. And I'll try and walk you through one of those cases, which actually referred to the clinic. You don't just get referred just because you have a foreign name and brown eyes and an illness. It sort of has to be sort of completely complicated and chaos. Everybody else has to be sort of have given up, and then it's us. So when everybody else given up, it's us. So we have fairly good picture of what's actually going on in the healthcare system. But they can also teach us things, and that's really, I think, the lesson here, that we ask the patients, well, what we do obviously doesn't work, so what do you suggest? And that's actually how we did. We started with pen and paper, and we invited the general practitioners, send us some very difficult patients, and we thought they'd send 10 or something, and they sent 100. So we had a waiting list and we had a problem, but we've been solving on the way. And most of the patients actually each of them have their own history and their own way of sort of messing up with the healthcare system, and we have, as a healthcare system, very many ways of messing things up by not understanding and not sort of accepting people coming from other countries. So this is the case about this. Abdul he's 47 years old. He's from Somalia. He's been living in Denmark for 10 years, I think. He suffers from high blood pressure, type 2 diabetes. He has a kidney transplant because he was subjected to torture and then his kidney was crushed. And he has a chronic hepatitis C, which he obtained from this kidney transplant that he got in Pakistan. It was a cheap one. He has to take 36 pills a day, and he's supposed to attend medical checkups at the hospital 3 to 4 times a month. He has a temporary residence permit in Denmark with his 2 daughters who's with him, but his wife and his 2 sons are in a refugee camp in Kenya. They were denied entry into Denmark. Abdul is not really fluent in Danish yet. He was, but he lost his job and he lost his language with that. He can't really remember when he was last offered a translator, but he remember there was one at one point. He has difficulty sleeping, and he's failed the language test, which could acquire him a better residence permit in Denmark. His dream is to become a truck driver, to have an independent life, and to support his family, but he has failed to pass the test because he can't read very well. Most of Abdul's friends are obese, they smoke cigarettes, and they chew cat as a form of self-medication. But Abdul, he doesn't smoke, he doesn't do drugs, he doesn't take alcohol, he takes daily long walks, and he eats food with lots of vegetables and fish that his daughters prepare for him. But lately, he's been checking out a bit. He's been gaining a lot of weight, and he has not shown up for his routine checkup at hospital. His blood pressure is rising, and his diabetes is out of control, and his kidney is starting to fail. The doctors have increased his medication a lot, which is quite expensive, and he suggested Abdul that he's put on insulin instead of tablets for his diabetes. The doctors fear that Abdul's kidney transplant is failing because Abdul forgets to take his medication. He was only referred to our clinic because they almost gave up at that point. And we had a translator, and we had time to let him talk about his issues. And he told us that he actually had some terrible nightmares, and that he had some things that he had seen and been subjected to during his prison stay, and other things that actually had led to signs of post-traumatic stress disorder. He spent all his money on medicine and transport to and from hospital. He's under pressure from his wife and sons in Kenya to bring them to Denmark and to send them money for school. And he's under pressure from the Danish government to pass several tests to obtain a better residence permit, all risk being sent back to Somalia, which they just started to do. And at the same time, he's under pressure from himself to become an independent adult man and have a good, decent job and a salary. Abdul has completely lost overview of his multiple health conditions. He had actually had overview of it, but he lost it. And he's therefore chosen to concentrate on just one illness. And he chose the cheapest one, and the simplest one, and the one with the nicest nurse. So he chose hypertension. I'll concentrate on that one and leave the other ones. I can't really deal with those. And he liked the nurse because he talked to him in a nice way, and she had a nice voice, and she acknowledged his problems. He's very uncomfortable in language class because of stress, and his mind keeps wandering off to Kenya and his family there. And he has very long flashbacks in class. Sometimes they talk about sensitive issues, and he has these flashbacks. And he's left anxious and desperate for days afterwards. And he's completely unable to learn anything. He tells his doctor he will no longer take the medication he's taking, as he argues, why should I take your medicine when it doesn't solve my problems? And then he said, sometimes you get one diagnosis, but you get 2 diseases. You get the pill disease, and then you get all the problems from that disease. You can't solve all the problems, but you give me pills for some of them. Abdul has discussed with his friends of the issue about these insulin injections, but his friends advised him not to accept it, because adult men don't inject themselves to eat. If you do that, you're nearly dead. Don't do it. So how do we preserve Abdul's actually initially good health behavior and protect Abdul against the risky health behaviors he's exposed to in Denmark? And how do we at the same time help Abdul with his socioeconomic problems and still support him to deal with his health problems? How do we make his diseases and illnesses his own? Research has shown that, in fact, immigrants in Denmark, they live longer than the majority population, actually 2 or 3 years longer than they do. But that's only because the Danish population, they smoke more and they drink more than the. So what are you actually integrating and assimilating, somebody call it? What are you integrating people into? Is that unhealthy behaviors or what? We have never really discussed those things. So why do we save Abdul's life? Just to expose him to an even more unhealthy life than he had before he came to Denmark. And how do we expose him to this non-responsive healthcare system? And why do we have excellent, hyper-specialized hospitals that are challenged by simple but multiple healthcare issues that Abdul is presenting with? Just as Abdul, refugees are most often under attack from several simultaneous stress factors. They have often insufficient language skills, and they have difficulties navigating around the healthcare system. And social welfare systems is also an issue, while their families and social networks are fragmented or even sometimes counterproductive. Illness and expensive medicine are not high on a refugee family's priority list. The survival of the family on a very small budget and concerns about the family not here in the home country are much more important than pills and diseases. And that is exactly where reality sort of strikes the hospital setting, where we have high speed and procedures and guidelines and everything is sort of always a production line, and then you have these complex socioeconomic health issues turning up in hospital. But this clash is not really necessary. Actually, Abdul started explaining his situation in detail when he had the assistance of an interpreter. We actually better understood his conditions. Stress reduced his overview, and therefore he picked and concentrated on one disease. So he tried to solve his issues and his problems in the way he could solve them. But with some help, he could actually solve more problems. He actually experienced less stress when he was allowed to explain for himself. It's just explaining, telling your life story is enough to reduce stress and give him some empowerment. And with less stress, he was actually able to concentrate on the other health conditions and start taking his medication again. So with a better understanding of Abdul's situation, the social welfare system was also able to better assist him and help him financially with the high expenses he had on medicine, which he didn't know he could get help for. This nice nurse talking to him was actually part of a training program that we have in the hospital, a voluntary training program where nurses that want to can come and have a 6-module training course, 1 hour every second week for a couple of months. And then they come back to each other and they have sort of an experienced network where they can discuss these issues. The doctor had also participated in a postgraduate training course on cross-cultural clinical issues and perspectives specifically on chronic diseases. And he was actually connected to this cross-specialty outpatient clinic that we had. The interpreter had also participated in a short course that we had hold in hospitals for interpreters so that we can include them in the clinical setting instead of them just being interpreter robots, and he was quite sensitive also to the issues that were raised. And the hospital social worker had also received special training in cross-cultural issues related to social medicine and social conditions and refugee law, for that matter. It's really a complex issue there. And he was put in contact with a refugee support group for chronically sick refugees, which helped him a lot. So he actually gained overview of his health condition, and his kidney transplant survived. So I think one of the main things here is that we're able to sort of demonstrate that patients can actually tell us what to do when we don't know what to do. And that training of doctors and nurses and social workers and having a slightly more migrant, diversity-friendly hospital setting can actually do a lot. And just by, we talked about trust. Trust is time plus language. And some persistence. And with trust, I mean, there's no problem. I mean, once you understand people's conditions, you can actually help them a lot. So this is an intervention, a cheap intervention. The politicians didn't like it in the beginning, but they asked us to calculate how much does this cost, sort of a cost-benefit analysis. So we did that. It was quite complex, but we did it. And we saved a lot of money, and then they shut up, so they let us survive. Thank you.
That's very impressive and very unusual, I think. one of the things I'm most curious about is the politicians came on board for the economic reasons, but can you quantify the difference in the health outcomes?
Sorry?
Can you quantify some of the differences in the health outcomes?
It's mainly, we try to evaluate the referring doctors and the referring social workers and with the patients. The patients was a bit of a problem because the usual way of looking at this was not really productive. It didn't yield anything. But if you sort of split up their functions in different spheres, we could actually better evaluate how old do you feel, for example. In fact, even if you don't know your age, you know how old you feel. Somehow everybody knows that. So this is a figure. So it's actually a sort of a blood test for quality of life. So we actually could see that they felt younger after having been through our treatment. So that's the only positive thing we can say. They felt younger and they felt less disorganized. And as one patient said, "Thank you for making a better version of me." And that's actually quite crucial because some of these patients don't like the version that they are made into in the foreign country. They remember how they were, lively and a family member and always funny and fetching water. And now they're sort of almost like handicapped, as I say. And they don't like it. They remember the old version. So trying to find sort of bits and pieces of the old version is also sort of part of the success criteria. So I think you need to look at other success criteria than sort of strict health indicators. But the doctor said, "This has made my life easier." I mean, it's not a secret that these patients can sometimes be extremely difficult in a 5-minute consultation at a family doctor, a GP. And they said, "This has made my life a lot easier because now I know what the problems are." We tend to make a long problem list. So we give the patient the problem list and the GP gets the problem list so they have something to work on.
Right.
So it's sort of a menu of problems that they can work on. But we sort out the problems so they look smaller.
That's very powerful. You said for Abdul the biggest difference was when he had somebody that could speak his language and could actually help him communicate. How easy is it to find those types of interpreters that want to work with this?
We have one interpreter bureau in this region that I work in. So we are able to sort of pick the best ones. So anybody's free to do that, but we do it sort of actively. So we know the competences of each interpreter. That's one thing. But we use a video interpretation system. The rest of the country doesn't, but we do. And that's actually reduced the number of, we had 30, 40 Arab interpreters before. Now with the video system, we only have 2 or 3. And they interpret from 8 o'clock in the morning to 6 o'clock in the evening every day. So they very quickly, they're experienced and they get some knowledge and they get some understanding on how you have these sensitive conversations that you have with these patients. So very quickly we sort of became a team. Instead of them just being a robot, they're actually part of the clinical team. And we ask them and we involve them and we involve the patients in trying to negotiate with the interpreter about this and then let me know what you find out. Because sometimes you can't just translate things. You need to discuss a lot of sensitive issues. You can't just translate them. It's a negotiation. So sometimes you have to negotiate.
Do you find clinics like this coming up in several other places as well, or is yours still quite unique?
In Denmark, yes. There's one in Copenhagen now, copied from us, and there's a new one in the northern region, and there's one coming up in the mid-region as well. We've been talking to people in Romania about this because they have huge challenges there in a different way, but we've made some training programs based on our setup for that. And in Norway, they've been looking at it in Sweden as well.
Thank you very much. We'll come back to more questions for you from the audience soon. Gowden, let me come to you at this point. This is Dr. Gowden Galea. He's based here at the regional office, and he is the director of the Division of Non-Communicable Diseases and Promoting Health Through the Life course for WHO in Europe. As a public health physician, he has held previous posts with WHO. In Fiji, with the Pacific Islands, where NCDs are a major problem. He also served as the regional advisor on NCDs for the Western Pacific region and in WHO headquarters in Geneva as the coordinator for NCDs and health promotion. He was quite instrumental in developing a national stepwise approach to NCDs that was first implemented in the Pacific Islands. And he was heavily engaged in the development of the UN high-level meeting on non-communicable diseases. And now he is working with colleagues here to drive approaches to health promotion and public health in various Europe action plans for WHO. Several interesting topics you're going to talk about get more into policy and governments, don't they?
Indeed. If I were to characterize my two colleagues, you've heard the intervention from the researcher, epidemiologist, the clinician, and I'd approach the problem from the point of view of a policymaker, both at a global and multilateral level as well as a national. A second prefatory point is that we've heard a lot about migrants, and the title has refugees and migrants, so I'll focus a bit more on the refugees. And thirdly, to pay homage to the region, our sister region, Eastern Mediterranean, that has a huge amount of experience of countries in emergency and have been dealing systematically with non-communicable diseases. So if I say anything that's meaningful, it's actually thanks to Slim Slama and Asmus Hamaric and others in Cairo, our sister region, who have been very helpful in my preparatory discussions. So one thing I did as part of the preparation for this is I said, what does the UN high-level meeting political declaration on non-communicable diseases say about refugees and migrants? So I downloaded the declaration. Well, I have it on my hard disk. I searched for refugees, then I searched for refugee, and then I searched for refuge in the hope. I actually then did a search for diabetes to see if the search engine was working, and I discovered that the 2011 political declaration does not mention refugees, but of course it mentions migrants. So no, migration, migrant, migra, none of those stems. It was quite a surprise because the high-level meeting in 2011 was very strong on making the link between non-communicable diseases, poverty, and the development agenda. And it is actually remarkable that it even by the end, it did not have a single mention of either of these issues. Oh, but I said there's the 2014 meeting, the UN review on progress since 2011, and its outcome statement. So long story short, I did the same set of searches, and refugee and migrants were not in the 2014 document either. This is very relevant, I think, to the discussion that we are having, given the millions of people who are experiencing either voluntary or forced migration, who are migrating or refugees from conflict or from emergency or humanitarian disasters, with NCDs being one can argue, and we have heard the evidence, the dominant set of conditions in these groups. It's almost unacceptable. It is unacceptable that we are in this stage of global inattention, and we in the non-communicable disease field have until 2011 smarted under the lack of attention that the MDG era paid to non-communicable diseases. So one knows what it is to feel left out of the policy agenda. Why do I make such a big issue out of it? Because there is a chance now for member states to address this. There is a new United Nations high-level meeting, the third in the series, about to happen. We still expect the General Assembly to bring up the modalities resolution, but we suspect that it will happen sometime in late September. And it is very important for heads of state going to that meeting to understand the importance of non-communicable diseases in refugees and migrants. And there I will draw the line. I think my top-line message on a global level is we really need to bring this up as a discussion between the member states and to generate a mandate. WHO is showing some leadership in this and work such as this very webinar, but in the collaboration in Europe between the Migrant Health Knowledge Hub and my own division, we're beginning to look at the implications of it for European countries as well as our colleagues in the Eastern Mediterranean, as I have said, have worked on this very intensely. So if you look at a population that is forced to migrate at some level of emergency, what are the top line, because we'll have questions and they'll have a chance to expand on this, but what sorts of things would one expect to see, what sorts of decisions would policymakers take in relation to this population? And it's best to classify it under the standard 4 components of non-communicable disease program. Governance, information, management, and prevention. So a word under each of those headings. In terms of governance, there are many opportunities for a whole of society and multiple intersectoral approaches to deal with the health issues of migrant populations. But in the context of refugees, of populations that are moving, the internally displaced persons in Ukraine, for example, fleeing from a conflict zone, what would a government need to do? Certainly, every government has national disaster preparedness plans. And it is extremely important to be looking at what non-communicable disease content there is. People who have been forced to move are experiencing a number of factors that can reduce their ability to live with their chronic condition. They are exposed to different cultures and to different behaviors. They may have been exposed to trauma. They may be wounded. It would such conditions torture, as we have seen in Abdul's example. This trauma, this violence reduces their ability, the body's ability to control their chronic conditions. They are in a new system where their access to health services may be limited by rules, by money, by income costs. And so standard issues of the health system start to come in. And standard operating procedures are extremely important. I'll come back to that under the management side. Information. Under surveillance for non-communicable diseases, we are interested in what we like to think of as the past, present, and future tense of non-communicable diseases. So if you want to know what were the problems of the past in terms of exposure to risk, you look at mortality. If you know what are the problems of the future, you look at risk factors. And if you want to know the problems of the present, you have to look at utilization of health services. And these three, shall I call them tenses of surveillance in non-communicable diseases, apply to a very great extent to this population. Indeed, three populations. You have the population of origin, people from Syria. How was it in Syria? What is the level of diabetes there? The host population, the population of Turkey, and the refugee population, the population of Gaziantep, to just take three very clear examples. And you need to know, if you're going to be planning, for example, the preparation of a kit for the provision of essential drugs for populations, you need to know what is the range of possible demands that you're going to get. Are you going to need a few drugs for diabetes or a lot of drugs for diabetes? In the Eastern Mediterranean region, for example, their average level of diabetes is about twice that of what we have in Europe. And there, you know, you're going to have a lot of demand. And that sort of data is fundamental. You need to know which are the facilities that you have that can handle refugees or migrants. I'm taking the more dramatic situation. So you need, in terms of the structures that you have, you need to know which health centers or health facilities are equipped to handle these inflows and these demands. And it's wonderful to have centers of excellence, but in a country that's facing a crisis, and this could happen in any country, you need to understand that your primary care centers need to be equipped to deal with the brunt of these cases, which takes me a bit into the management. In the acute part of the movement or the emergency, you're mostly concerned with continuity of care. You have a chronic condition, and most of the problems are going to arise because people are stopping their diabetes medication, stopping their hypertension, don't have their asthma inhalers, can't monitor their blood glucose anymore. So these stoppages are the things that bring the exacerbations, the emergencies in these populations. And therefore it's important on the management side to understand that this has implications for what are the essential drugs, how much of them do you have stockpiled, how quickly can you get them to the places where they are needed. Becomes very mundane questions, but they can be a process or an issue of life or death. And I leave prevention to the end because prevention tends to be what we always talk about when we consider non-communicable diseases. And in the long term, of course, we want to be able to prevent. But it tends to be, you're not going to take a smoking history of a person who's fleeing from torture. At that point in time, you have physical conditions, mental conditions that you want to take care of. And so one can see prevention as a sort of two-stage approach. One, prevent the acute emergencies. Second, look at risk levels. Charles mentioned the risk profiles and very appropriately said that you can't just use the risk profile of one population and another. And indeed, there's a lot of debate as to which risk profiles. But sometimes having something is better than nothing. And so at least being able to take a basic understanding of what is the cardiovascular risk that people are however roughly assessed, and to try to use that to triage or to provide treatment. And finally, of course, at the stage where you have populations that are more dispersed, more within the general population, you can start to think of preventive interventions that are culturally appropriate, adapted to situations where prevention becomes, dare I say, more routine. Whether you're Syrian or Italian, or Turkish, you're going to respond to price signals. So if you raise the taxes on tobacco or alcohol, it's going to work. And there is a lot of evidence that shows that people who are poor are going to be even more responsive to price changes and adaptation. So then when you get to the more, dare I say, normal prevention, then you can actually think of the refugee and migrant population as being somehow more, dare I say, integrated in their types of response that you would expect to see.
I want to follow up on that last piece that you just mentioned. When these emergencies happen and you suddenly have refugees, what advice would you give national health systems? What type of preparations would you suggest that they make in order to be able to handle the emergencies and the refugees because of it?
I've hinted at some of it. Mm-hmm. So, for example, one will have standard operating procedures on what to do with this type of condition. Our colleagues in EMRO have done a very nice job in translating the so-called package of essential non-communicable disease interventions that has been produced by WHO globally. And they have adapted it into very simple, for example, 2-page flowcharts where diagnoses of cardiovascular disease, diabetes, chronic lung disease, or mental illness, they combine all four, whereby they have simple tools, simple flowcharts. You're not going to turn high-ranking people into high-ranking professors of clinical medicine, but you are going to provide the triaging and the primary health level of care, primary health care level of treatment that you can with that sort. Also, under these four headings, they have produced lists of essential drugs and lists of essential technologies. So they range from antihypertensives, basic antihypertensives, to glucose meters. If you look at the list, many Western European countries would think it too basic. But the beauty of that too basic is that you have enough to treat the main conditions at a very cheap cost, so that the issue is not of price anymore, but it becomes an issue of logistics. Can you bring them together? Also, to look at the systems. For example, if you're expecting people to be moving around, don't create a system of record keeping that is static. Put the record on a card, keep it in the hands of the patient, and make sure that when they move around between countries, between camps, or when they run away, or whatever is the issue, when they move, they at least have enough information to identify what treatments they have received, what conditions have been ascertained, and so on. So, one word, well, three. Standard operating procedures. Make sure that in all the disaster recovery emergency plans of the country, there is an issue of non-communicable diseases considered.
Terrific. Thank you very much. Let's give everybody else a chance to ask some questions at this point. So if you're in a room, we'll give you first chance, but let me just remind everybody online how they can participate as well. If you joined us late on the website, beneath where you are watching this webcast, you can go to a box that says Ask Questions, and you need to type in the event code, KHHM. And if you are already in, and it looks like we have a fair amount, it looks like we have 17 questions at this point. What I'm going to do is take 3 questions at a time and let our panelists work their way through those, and then we'll come back and take another 3 so that we can cover as much ground as possible. If we get too many and run short on time, and we have 25 minutes, then I will actually turn to Joseph and see if there are some consistent themes in the questions that he can sum up for us so that we can get more questions covered that way. Let's start in the room. Does anybody in the room have questions? 1, 2. Let's take these 2 questions and then we'll go to the website. I think we have some roaming mics. Yep. Yeah, you too. Okay.
Hi, thank you very much for that talk. It was really insightful. One topic or one theme which kept on being coming around from the panelists was about migrants and refugees coming to a particular country and then settling down. Could you enlighten us about the topic of NCDs and refugee camps? How do the professionals over there, is it a very recurrent theme? Is it something which is being addressed? Or do they look more short-term rather than look at the picture of NCDs?
Let's go to the second question, and then you guys can start thinking about these.
My question was a question for Morten. It was really wonderful to hear about the very interdisciplinary approach that you're taking in UNSA, because that's something we talk and write about a lot at WHO. I'm just curious, I know that the barrier for funding was lifted with an economic argument. Did you encounter barriers with the colleagues from other sectors like social work, education, etc.? And how did you work on those barriers?
Yes, sir. Yes. A microphone will come to you.
Santino Severoni, migration health program here at the regional office. A question for all of you. Actually, I really enjoyed all three interventions. In addressing NCDs, there are a number of issues. Gordon, you mentioned that the topic is completely forgotten in key policy papers, but not only. Observing the first aid kit provided to refugees and migrants at the first arrival spot in Europe includes cigarettes, for example, together with a telephone card and personal hygiene kits. So my question is, how much the economic argument of neglecting prevention of communicable disease can help us in addressing NCD among migrants and refugees?
And at the end of this, if I could take the prerogative and have you give us some closing statements, would that be great? Thank you. All right, who wants to begin? Charles.
Well, I think that this is a very interesting and important point that is raised by the speakers. Particularly, you are talking about what is actually happening in refugees camps and others. I think that studies, particularly among NCDs in refugee camps, not many, because I think that the priorities within these camps are usually given to communicable diseases in general. But I think that it's about time that we actually take this very seriously, particularly in a country such as Syria, which is actually a wealthy country. So many people are now moving who, for instance, have diabetes. So it becomes an emergency. It's not only communicable disease, but also non-communicable disease becomes very important. I know that there has been some studies, particularly in Jordan, where they've been looking at this, particularly in terms of access and others. And some of these studies clearly shows that there is a clear need for taking NCDs very seriously within these camps. So from my perspective, I think that the point that you are highlighting clearly shows that there should be more needs to be done in taking NCDs very seriously. And I think this type of platform will help to probably give attention to that. Yeah.
I don't want to go into detail about refugee camps as such, but we did some research, longitudinal research in northern Uganda in the years just after the conflict ended. And we could see that there were some issues where some groups, age groups, and particularly women gained more weight, even under sort of the limited food rations there, and actually some of them were obese, even in refugee camps, while the young men and older men were actually malnourished, very, very thin, within the same camp setting. So maybe World Food Programme would like to have a closer look at their own sort of algorithms and how to distribute food. And we've seen in other contexts as well that the well-off get more food, and the poor immigrants get less food. So we also have sort of, you induce some NCDs just by the way you distribute food, maybe. So that's just sort of, it's a funny angle of it, but it's actually quite serious. It looks, and it has some long-term consequences. And to your question there, yes, of course, this is the ugly duckling in the healthcare system. No doubt about it. But if you have good cases and you help, nobody will argue with you. But you have to show. Don't tell that what you want to do. You have to show it. So you have to have cases that you show. This is how you do it in your department. Let me help you. Try and get an interpreter, and I will be with you for the first couple of times you talk to these patients, and then I can teach you. So we have some obstacles there. I think actually the social welfare system was the first to adopt the idea, because they were also frustrated. I mean, they have the same hyper-specialized way of working, and they had these sort of complex issues that went across sectors, and they couldn't really deal with them. So they phoned us, can you help us try and give an overview of this family? Because they were not allowed to sort of combine information about the children and the adults in the family. They had to be kept separated, but we are allowed to do it. So we could actually help them sort of give them a good overview of what is a family issue here, what are family issues in general in these families. So very quickly they became our best friends, and some of the most hardcore enemies that we had, we actually just had to show them. I mean, we have 5 cases here. Look what happened. Should we help you or not?
Camps, sketchy to none. It's not a good picture at this stage. The interagency emergency health kit did not include non-communicable disease drugs until late 2016. It's not 30 years ago. And we are seeing now improvement with the EMRO kit that has been developed, and one would like to soon see a picture of it being available as routine in all camps, but that is not yet the case. Again, isolated examples of good information. For example, in Gaziantep, they organized a full-scale STEPS survey. In Georgia, they used the population STEPS survey to assess, with the International Organization on Migration, to assess the impact of NCDs in the internally displaced population. So you do get uses of routine and ad hoc sources of data in order to try and characterize the size of the problem. But the time when you could assume that a camp or a displaced population had access to people who were trained in the management of NCD and who had the drugs and the technologies that they needed, they're still, I'm afraid to say, far in the future. Economics. I'm scared a bit to use the economics argument. I know Dan is sitting there at the back, and our friendly health economist. It's only one step away from a politician saying the cheapest way is to let them die. And so if you go too far down the economic argument, you may be playing into the hands of certain extreme views where the financial side and the economic side can be a problem. And cigarettes, oh God, giving them to people who are yes. So it's maybe I don't know what to say to that. The inconsistency. When I said earlier, I didn't know this one. I didn't know about the first aid kits containing cigarette packets. I have no words to say. The massive inconsistency and the absolute inability. Sometimes when people talk about intersectoral action being difficult, I say, wait till you see how difficult it is to get intra-sectoral coordination, because one team tends to disregard the evidence of the other. What can I say? I am appalled.
Can I probably touch on the economics part, because I think that this is a very important point, and I think probably you have to look at it in which way to address it. Of course, I mean, you have a point that can be abused, but I think it's equally also very important to really educate the society about the importance of treating these people. Because for ordinary person, if the people can be made to understand that if you neglect these people, in the end, particularly those within the country, in the end, it's going to be very costly. And you can just use a very simple examples, like I has used. If you help someone is on has a high blood pressure, and you help the person to be controlled, you can save tremendous amount of money rather than the person having stroke and getting to say high dependency in it. So these are very important points. I think we need to clearly make clear to that. So I think for the economic argument, I think we can. How do I put it nicely? We can package it in such a way that is understandable, but at the same time making sure that it doesn't become a political football for that. Yeah.
If I may take a slightly controversial view on it.
Somebody asked the right question.
But I think it's important for us to, we're not disagreeing, but I think you have to see the two sides. Yeah. I completely agree. And on Tuesday I will be in Montenegro presenting an economic argument for intervention on noncommunicable diseases. the point is taken. It's extremely important, though, to understand that that there is a difference between the financial argument and the economic argument, and that the valuation of health and quality of life and the duration of life is extremely important to take into account. And when you just look at healthcare costs, even just think about what we're considering here: get interpreters for multiple languages, high quality tertiary care centers. If you look just at the direct healthcare costs in the scale that they are needed, when you have numbers, I think it would be difficult to claim that it is cheaper to do prevention or to do proactive care than it is to just let people get some intensive care in the last 3 months of their life. But we could argue that as an academic point. It's worthwhile researching it, but I would be careful about how to use it.
But you cannot argue it as an academic point anymore in this next 30-minute window, because we have some questions coming up, some very popular questions coming up that actually link very closely to what we were talking about today. Mazen says, lower trust in healthcare among migrants can lead to lower utilization of services and prevention programs. This is well known. What can be done to rebuild trust in a health system? All right. The second question comes from Stephanie. If you could cast a spell and lift one single obstacle standing between migrant populations and healthcare, one, guys, one. She only said one.
Wow.
Where would you wave your magic wand? And from Roman, we have migrants often come from communities where NCDs, lifestyle diseases, should be less prevalent. What factors contribute to NCDs increasing among this population? Morten, you've been very quiet over the two people fighting between you. I will let you start.
There are some huge Indian studies on migration and health, and they clearly show that when you migrate from a rural area to an urban area, in 1 year you gain weight. It's about 3 or 4 kilos or something on the average. And after 3 years, your risk of hypertension, high blood pressure is increased by, 3-4 times? I mean, just by settling in a city, no job, fat food, and nothing to do will increase your weight. So I think that's a simple version now. I think Lebanese Palestinians living in Lebanon, they have a 7% risk of diabetes. In Denmark, it's 22%. So I mean, you found the same thing. I mean, it's fairly simple, I think. It's about food, it's about physical activity and possibilities, and also about not knowing what to do. I mean, you very often, if you don't know what to do, you become inactive. So it's generally an inactivity issue. There are some huge ethnic differences. And I think somebody's making this annual sort of overview of index of physical activity by ethnicity. And there are huge differences, even in home countries, between ethnic groups and how much they think they do. Well, then you actually measure it, is less of a difference. But there are some psychological and context-specific issues, but also related to how you can move and behave and eat when you're in a different context. But even moving from a rural area to an urban area, even in Denmark, I think it demonstrated that you become fat. You don't do anything. So that's, to me, the simple version of it. And the other can we have the other questions?
It's trust.
Trust.
Is,
How can we rebuild trust
I think
in the health
we
system?
touched upon it, but one patient said to me, I would be strong in my own language. I could take care of myself, I could handle this disease, no problem, in my own language. But speaking in Danish, it's like being a child again. Or driving, as one said, it's like driving a car with 3 wheels instead of 4. I mean, it's a bit shaky and I'm not really sure where we're ending. So I think the basic issue is to eliminate the language barrier, because most people are quite normal when you get to know them and you speak the same language. And they can argue, they can enter into a dialogue, and they can talk to you about their risk perceptions and knowledge and attitudes. So we can negotiate and we can find a solution. I mean, a lot of people talk about cultural competence. I don't really think that's where we're going. I think we are more going into talking to each other in the same language, and that requires an interpreter. And one of the main issues here is that you learn to be sick in your maternal language. I mean, you learn to throw up when you're 3. You learn to have a fever when you're 4. You learn to have diarrhea when you're 7. I mean, it's a childish maternal language issue to be sick. So you have to start talking about illness and treatment, for that matter, in your maternal language. Otherwise, it just doesn't make sense.
So would language also be the barrier that you use to remove with your magic wand?
To me, yes, that's the only one there is, and there are no other
rebuilds
ones.
trust in health systems.
Yeah, because then it's all only about social determinants and stuff like that. It's a completely different sphere. This is only about language, I think.
Charles.
I think that's a very important point, particularly in terms with trust. I mean, some of the work that you've done in Amsterdam, one of the key things that actually coming out is trust. Because the migrant populations, as I previously mentioned, tend to live in their own world. So interacting with the wider world becomes an issue. So there's a tremendous amount of distrust within these communities. First has to do with the language, and also first to do with the perception of unknown. And I think we also need to remember about history, the history of healthcare systems, and how healthcare systems has been not always been, how do I put it politically correct, not always been right in treating minority population. I mean, the US in particular, that there has been serious. So there's a deep-seated mistrust. So to do so, I think that you need to get the migrant community members themselves, those that know how the system works, to be part of the system. If you do that, then it makes it easier. For instance, if you go to hospital and the whole hospital is completely with European workers, as a migrant, you feel out of place. So it's very important that the health systems take into account the migrant population and try to also employ a migrant population within these services. And that's not only on the low-paid jobs, but also across different levels of the healthcare. And that could help to give a lot of trust among these migrant populations.
Dalton.
No controversy, believe it or not. Tampi. But some reinforcement. Trust, I would add information to language. Reflecting on my own experience of migration, at least 2 of us have been migrants. This is my 4th country in which I have lived for any length of time. And certainly none of it was forced. I was in no sense a refugee, it was all by choice. But when you enter a country, getting just the health system, what rights you have, how you can access it, these are immediate concerns that you have, however normal your level of migration is. And I have experience of how different societies expect you, for example, to be completely dependent on the private sector. Others will allow you some access to the public. In some cases it's conditional, but understanding these things is in the language very often of the country, not in your own or any common language. So these big barriers are there to any level of migration, and I think any health system that wants to integrate or support refugees and migrants to any meaningful extent needs to make sure that this information is available. Ideally, the conditions are, so I'd go to what I would change, the magic wand. I would like the concept of universal healthcare to apply also to, we talk about it a lot, but it should also apply to refugees and migrants. It's extremely important to consider a scale of vulnerability And at one end are the normal entitled population, the native, the host population. At some other end, there are people in various levels of unemployment, levels of poverty, poorer income, or refugee status. And I think it's, from the health system point of view, how well you deal with the refugees is actually going to be a reflection of how well you deal with the vulnerable people in your own host population. And maybe it's my magic wand would try to do an assessment of the system and see what needs to be changed for people at all levels of disadvantage, not just the ones who are refugees. I'm sure we would diagnose common problems across all that continuum. Do you want to move on, or factors? Factors.
Go ahead.
NCDs have been are really the expressions of sickness of societies, not just of individuals. We have the corporate consumption complex that makes sure that the cheapest foods to buy are those that are simply a concoction of fat, sugar, and salt, pulled together in attractive ways and marketed in interesting ways. Kept very cheap, but because of the basic, very low cost of the raw ingredients, of the raw materials, the profit margin is greatest. So if you were a refugee entering a country, if you had a small stipend that was generously provided by the host country, and you had to go and buy, you would only be able to afford a basket. So apart from all the cultural factors, I'd like to say we need to also look at the toxic environment that people are in. And if they're further given cigarettes in their first aid kit, I would say case closed.
Very good. Before we go forward, those of you on the app or the website, there is a survey being put up about this particular event. If you could just take a moment and fill that out, we would be extremely grateful. The question at the bottom there, I think Galvin addressed very nicely. How can standard operating procedures be introduced to the migrants and refugees as they arrive? We also talked about what type of interventions could be used. So I won't ask those two questions. Instead, I will go ahead and start wrapping this up by passing it over to Dr. Severini.
Well, wow. My comment is wow. Beautiful webinar. I'm just astonished, and I would love to keep talking, like usually is the feeling after webinars. Thank you, gentlemen. Really, you made a fantastic contribution to our difficult work on refugees and migrant health. Christy, thank you. You made everything wonderfully blended and stimulating. I want to take the opportunity, just a few practical informations. This is one of the series of webinars we are running here in the house, thanks to the ongoing collaboration with a knowledge hub supported by the Sicilian health authorities and the MICMA project, Migration Health Knowledge Management, funded by the European Commission, because the aim is exactly to bring more actors, stakeholders together to work jointly towards a common objective. The UFA you are also representing, Charles, is with us since the very early stages, and we are preparing already for the next one. Again, on NCD family topic, mother and child health, in April, but more webinars will come also on other topics. Just for who is connected in remote and people here in the room, we are supporting those webinars also with the production of advisory guidance, technical advisory guidance on different technical topics, and Joseph is coordinating with a wonderful crowd of experts in different areas. And we went live in December with a Knowledge Hub website where actually the webinars can be listened again. So there is a repository there of all webinars. So allow me to thank you again all for this wonderful contribution and participation. Thank you to my director, Piroska, for her support, but also I would like to thank Joseph and Edvig for their own incredible work. They made possible this webinar, and the communication, Chelsea, the communication colleagues for continuous support. Please join me with applause to everybody. Thank you.